Thank you so much, everyone, for joining this morning, and thank you for the invitation. I'm going to walk us through a little bit on some of the tools we have to make a diagnosis of SCAD. Again, you might think it's sort of straightforward, but oftentimes these cases are a little more complex and a little more challenging. And as we heard, being able to make that diagnosis, being comfortable in that diagnosis is critical because our management differs from other types of myocardial infarction or heart attack. So let's start with the case. This is a 35-year-old woman. She has a history of high blood pressure, and she's had about a week of what she thought was indigestion, but it seems to be getting worse, and she's had some pressure in her upper stomach. She's tried all the usual antacids, and it's really not getting better, and she thinks something's off, so she decides to come to the emergency room. Now, any patient that's coming in with pain in the chest, pain in the upper belly, we always want to make sure this is not a heart attack. And I think it's often overlooked, but the first critical thing is to really go through our medical history, our history of those symptoms that she's having, and do a physical exam. That's critical to change our thought process about the presentation. So we want to know how a patient describes these symptoms, especially pain. And some descriptions make us more concerned about something going on with the heart. Some of those descriptions may make us less concerned. So things that are more concerning, when it's centralized, it's pressure, tightness, squeezing. Does it get worse with exertion? Does it get worse with emotional stress? All those things would make us a little more concerned about a blockage in a heart artery. Things that may be more reassuring to us, maybe in a different part of the chest, right-sided. Does it get worse with a deep breath? Or in particular, when it's a fleeting episode, when this lasts just for a split second, that's a little more reassuring. But again, you have to put this into context. This is a patient who's saying, something's wrong. I'm a young woman. I've decided to come into the emergency room. And so you want to respect that and not be too falsely reassured, no matter what the description is. And when we look at patients who ultimately aren't diagnosed with SCAD, certainly the majority have some degree of chest pain, but they do have other symptoms, nausea or vomiting. They can develop shortness of breath, back pain, or may just describe fatigue. So again, we want to be asking about all these other associated symptoms when we're evaluating these patients. We heard about the association between SCAD and things like fibromuscular dysplasia, inherited connective tissue disorders. And so I think some of these questions when you're evaluating patients can be helpful and may increase or lower your concern for SCAD. So for this patient, starting off, 35-year-old with high blood pressure, I'm automatically saying, well, that's unusual. Something's going on there. Does this represent underlying FMD or something else? So that would change how I would think about the patient. Do they already have a history of stroke? Do they have a history of aneurysm, dissection? Do they have migraines, pulsatile tinnitus? Again, you want to start incorporating some of these basic questions into this evaluation for a young person with chest pain. And again, this could help you raise concern for something like SCAD. Family history. Again, I think this is often maybe overlooked in a busy emergency room, but I think this is critical. You certainly want to ask the patient, do they have a history of heart attack or myocardial infarction in their family, especially at an early age? But do they have things like FMD or SCAD in the family? You'd be surprised. You may not be suspecting this, and they say, well, I've got a history of Marfan syndrome in an uncle, or so-and-so had an aneurysm in the past. So again, you want to start incorporating these into your family history because it could influence how concerned you are about something like SCAD. And then, of course, the physical exam. You're going to do your typical cardiovascular examination in this patient, listen to their heart and lungs, listen to their blood vessels. But again, you want to be able to incorporate some of these things just when you walk in the room and see a patient at the bedside. Do you notice changes in their eyes, in their jaw? When you're listening to the lungs, you can check their back for scoliosis. When you're listening to their heart, you can look for a pectus abnormality. Tall, thin stature, look at their hands when you're checking their radial pulses. Again, picking up clues that may make you think, is there an underlying connective tissue disorder? And if so, now I'm even more concerned about something like SCAD or another similar diagnosis. Now, I think everyone who comes in is going to get an EKG. Sometimes you get a very dramatic EKG with ST elevations and sort of a slam dunk diagnosis. A lot of the times it's more subtle. And again, you may be kind of on the fence about what's going on. For this patient, she's got a little bit of really sub-millimeter ST elevations here in the anteroseptal lead. She's got some T-wave inversions. But of course, you don't want to overthink it. This is a young woman. This is not a normal EKG for this type of patient. You've got to account for this somehow and then move on to other diagnostics to help figure out what the underlying process is. Now, I think a lot of the patients on the call are familiar with the troponin. This is a blood test we use to look for damage to the heart muscle, commonly available in pretty much all emergency room settings. There are different cutoff values for men and women, and that will be kind of incorporated into how this is reported out. It should be normal. If it's above that limit, you have to figure out why might that be. It doesn't automatically mean it's a heart attack. There are some other possibilities, but again, I think it's important for clinicians to say, this is abnormal. What are the possible explanations? And I've got to put my money down on one of those explanations. And for patients, you may be having more than one troponin checked, right? So if you're coming in and as soon as your symptoms happen, it may not be detectable in your blood yet. And so you may have more than one test to see if that changes over time. So for this patient, this was not subtle at all. She had an elevated troponin of around 6,800 when she first came in. So quite abnormal on that first draw. So something's going on. I think another tool that can be helpful, and I think every cardiology fellow is familiar with this, if it's a situation where you're not 100% sure, maybe a mildly elevated troponin or that first one's normal, but you're still concerned about something with the heart, you can get a quick bedside echo and see how the heart is functioning. And so here's an echocardiogram from our patient who came in. And now this is an apical two-chamber view. We're looking at the left ventricle. And I would say really this anterior wall here, it's not squeezing as vigorously as it should. Again, this is a young, healthy woman. This should be a completely normal echo. This is not normal. I'm even more concerned about this patient now. And I think it's very clear she's got EKG changes. She's got symptoms. She's got a markedly elevated troponin. She needs to move on to a coronary angiogram. And we're looking for, again, it could be an atherosclerotic myocardial infarction, but it could also be SCAD, and looking for some of those features we heard about in the last presentation. So let's look at her angiogram. Now, this is a pretty dramatic angiogram, pretty clear-cut diagnosis here, I would say. We're looking at the left anterior descending artery. You can see sort of that sharp narrowing, that tapering of the vessel. You have this string-like appearance after that, a little bit of the dye that's getting past it. And you can see the rest of the blood vessel here is very sluggishly filling. So a large blood vessel that's affected, pretty clear-cut answer. But one key thing here is you need a high-quality angiogram to make this diagnosis. They are not always as simple as this. So the technical components, you need to make sure you're well engaged in that vessel. You're completely filling the vessel with contrast. Often you're looking at tiny little branch vessels. You need to make sure you're panning and staying on long enough to opacify those and look at them. And so every interventionist will say it takes a high quality diagnostic angiogram to make this diagnosis a lot of the time. Now, let's say you do that angiogram and you're just not quite sure. There's a little blood vessel that you're saying, this could be SCAD, but I'm not 100% sure. I can't get more information from that angiogram. I do think a coronary CT angiogram can be helpful. So again, taking the patients out of the cath lab, doing this as a follow-up test, and there's certain things you're looking for. Maybe you get lucky and you can clearly see one of those dissection flaps. There could be some changes in the fat around the blood vessel that can suggest dissection. So again, as long as you've got a good group of radiologists and cardiologists who are performing and interpreting these scans, this can be really helpful. So here's a patient. Number one, I'm saying there's really no coronary calcium at all in this blood vessel. It looks like a healthy blood vessel. Until we get down here, you can see some tapering and then a normal blood vessel afterward. Certainly concerning for SCAD, and that matched this person's angiogram. So again, that's a nice example of a CT angiogram that's making that diagnosis. Again, here, if you get lucky, you might see this, First and foremost, a nice healthy looking artery. I don't see a lot of coronary calcium, but we got lucky. We can see a dissection flap here. So again, another example where this imaging modality can be helpful. Another thing that's often overlooked, I think cardiac MRI is great for any person that comes in with suspected myocardial infarction. Let's say you do the angiogram and it's completely normal. You can move on to this modality. And like in this case, this person had late gadolinium enhancement that appeared consistent with what you'd see in a myocardial infarction. You could have flush occlusion of a side branch vessel, something like that, that may be missed on an angiogram, and this can help make that diagnosis. And then, again, would help change your management of this patient long term. The other thing we heard about, we want to look for these other extracoronary vascular abnormalities, things like fibromuscular dysplasia, aneurysms or dissections, not just because you want to manage those, but that can help you when you're on the fence. Is this SCAD? I'm not 100% sure, but if you do that head to pelvis CT angiography and you get clear-cut FMD in another vessel, I'm much more likely to be comfortable making the diagnosis of SCAD. And Dr. Kim helped us develop a protocol at Vanderbilt where this is going to be done really just as one study, head to pelvis. And you can see how common this is. Among this group of patients with SCAD, 56% had some other blood vessel abnormality, again, really helping to cinch that diagnosis. Looking for things like coronary dissections, or these are patients with multifocal fibromuscular dysplasia in the kidney arteries there on the left and the iliac arteries on the right. Again, really helping you be comfortable in that diagnosis of SCAD. So a few key take-home messages. Again, not all chest pain is SCAD in young women, but if you don't think about SCAD, you will not diagnose it. I really think that you need a high-quality coronary angiogram to help make that diagnosis. But in situations when you're on the fence, use all your other tools. Use coronary CT angiogram, use cardiac MRI, or use that CT angiogram of other blood vessels to look for FMD or other of those extracoronary vascular abnormalities. Thank you, and we'll stop there.